So what we're gonna do now, is just get right into the actual leukemias, okay? So I'm gonna give you a few more slides to cross out because this is just setting the stage for what we need to do. So if you guys can cross out 22 through 25, because I need to get right into the actual leukemia. So let's get right into 26. 26, so we're going to get right into this, CML. So this is the first leukemia that we're going to cover. And CML, we already know when we kind of broke this particular abbreviation down. So it's a chronic leukemia. It's attacking a mature cell, a myeloid cell. And just to give you a heads up, most of the times, let's say the leukemia will attack, especially if we're talking about a myeloid cell, it's going to attack the most abundant white blood cell circulating. Okay, so just to give you a hint. CML represents approximately 15% of cases in the U.S. I don't need you to memorize the percentages, however, I would like you to memorize the age range, 40 to 50, because when we do have some test questions that are like case study type questions, that those ages will kind of help you. So 40 to 50. This is considered to be more of an adult leukemia, not a child type of leukemia. However, can children and adolescents get this? Yes, but it's not that common. It's a little rare, but mainly this is an adult leukemia. This leukemia does have a hallmark, and this is the hallmark. Okay, so this entire slide really is the hallmark. The hallmark here is that they do have a particular chromosome. Okay, so a doctor did discover that individuals that do have this type of leukemia, he pretty much actually found an altered gene expression. He found that there is a particular chromosome that is only found in these individuals that have this type of leukemia. Okay, so it is called the Philadelphia chromosome. Okay, and it's named Philadelphia because it was discovered in Philadelphia. Okay, so which is weird because usually the scientists, they usually name it after themselves, but he named it Philadelphia. Okay, so this is a translocation of chromosome 9 and 22. These two genes juxtapose and they will convert over and form what is called a new gene. So I'll show you a picture in a second, but basically the two chromosomes actually join, but when they join, they do not transfer over all of their genetic material, which means that some of the material is left over. That leftover material now makes a new gene. Okay, and obviously that's an abnormality. And so that's the new gene that they call the Philadelphia chromosome, which they find this in these individuals that have this leukemia. Okay, so yes, the new gene is called the BCR-ABL. Okay, and so another thing that happens with this type of leukemia is that it also reduces apoptotic cell death. Okay, so if you remember from physiology, apoptosis is programmed cell death. As I said to you earlier, cancer cells do die. They do undergo apoptosis. However, not as fast as we want it, unfortunately. The problem that we have with some leukemias is that they have a reduction in apoptosis, which obviously makes the lifespan of the leukemic cells longer. Okay, so that's not good. Okay, so let's take a look at this. So this is what I was trying to explain to you. Here's chromosome 9, 22. They join together, okay, and then they transfer. However, there's still pieces of this material that does not transfer. So those extra pieces of material do form a new gene called the BCR-ABL. Okay, and again, they do believe that this is found in those individuals that do have CML. Okay, so that's the altered expression right there. So this is the hallmark, okay, because this is the only leukemia that, from my understanding, has this gene. So this is the pathology slide. So let's take a look at this. I don't think I need to turn the lights on. You guys can see. First of all, chronic, mature. We are looking at mature version of a white blood cell. Now, I will tell you, believe it or not, these are supposed to be neutrophils. Okay, now we already know what normal neutrophils look like. These are leukemic neutrophils that you're looking at. So, just to go over what makes this cell mature, if you look at the cytoplasm does have granulars, it does look pretty decent. However, when you look at the nucleus doesn't have that trilobe or multi-lobe shape, okay, that we saw in a normal neutrophil. This actually has like that U shape, kind of like a monocyte. Some of them look different, kind of distorted. So these nuclei are actually distorted into different shapes. Why? Because keep in mind that they have that altered gene expression that occurred, which means that their nuclear material in the nucleus is different. So this is showing the signs of malignancy, okay, just within that nucleus. Another thing that tells us that this is malignant, you see all those neutrophils clustered together? That's not normal. When you guys in anatomy scanned your blood slides, okay, you were just practicing, did you see that many neutrophils? You actually had to scan a couple of times to find some of these white blood cells. Yes, you had to scan a couple of times, so you really did not see neutrophils in that abundance all in just one field of view. Okay. Now, just to give you a heads up, if you had a person, say maybe if they're undergoing some sort of infection, okay, and you see, okay, that right away, they may have more neutrophils maybe in that field of view, normal neutrophils. However, as you can see, this is definitely an abnormality, abnormal neutrophils all clustered together. Two things I want to point out that's kind of an artifact. This cell, and I think also this cell is dying. It's on its way out, okay? Another thing here, you see this cell, how it has holes? This is undergoing apoptosis, so it's also dying. So keep in mind, we do have cell death that occurs, unfortunately, again, not as much as we want. Now, what's going on with those red blood cells in the background? Do they look good? No, not at all. Those red blood cells actually are very light, okay, and some of them have look like they have holes in the middle. As you can see, there is definitely a huge lack of hemoglobin in those red blood cells because the color is off. The other thing too, if you guys remember in normal histology, you would have red blood cells that would cover every inch, okay, of that slide. Here, you're seeing a lot of open spaces, okay, and that's not a good sign because that's telling us that that person most likely has a decline in red blood cell, most likely an anemia, okay, just by looking at that. Okay. So, the clinical presentation, with chronic leukemias, and I'll let you know this now, sometimes the signs and symptoms are not abrupt. They're not in your face, like immediately. So they take a little longer time to develop. So when they do come out, sometimes they can have fatigue, weight loss, sweats, bleeding, and abdominal discomfort from the splenomegaly, okay? So let me go over sweats. I just want to clarify something because your book, I really don't like how they have it labeled sweats and the night sweats, so just in case when you read the chapter, they have sweats labeled for CML, and then when you go over lymphomas, they have night sweats, okay, and so that's kind of confusing. That means that is this person having day sweating, okay? So this is what happens. When we talk about sweats, sweating can be anything. I mean, we could be in this room sweating right now. Sweating we know comes from when women are going through menopause, people that go through hyperthyroidism, okay? Sweating can be from a number of things. When we talk about sweating in chronic disease processes like cancer, even sometimes patients that have HIV and AIDS, so when we discuss that, they do have sweats that occur. That sweating, and I was even taught this way in school, that sweating is what is called sweating at a resting state. Because if you're sweating at a resting state, we know that if you're resting, everything should be slowed down. Metabolism, everything should be calm, okay? But if you're sweating in a resting state, that means that your body is definitely undergoing this disease process where it's fighting, okay? And so this is what we're talking about here with sweating. And I just want to make that distinction because I don't know why they have night sweats.
Well, it's called cold sweat,
day
no?
sweats, but yes.
Is it called a cold sweat?
They call it cold sweats because your body's resting. So your temperature's low also when you're resting, okay, and your metabolic activity, everything's slowed down. Yes?
What if a woman's going through menopause? How would they know if it's from the menopause or from cancer sweats?
Yeah, because menopause, you get a cold sweat too. By the time they're sweating, they're going to have other things going on.
Oh, okay.
So they'll have fatigue and weight loss, and so they should have other signs and symptoms with it. I just wanted to make a distinction with sweats because they're making this sound like day sweats because they make a distinction of night sweats with the other lymphomas. So, but again, if you just look at it as sweating at a resting state, okay, sweating at a resting state. So as far as treatment, they say CML does not respond that well to just chemotherapy alone. Unfortunately, if it's untreated, the survival rate is 2 years. They do, however, and this is good, because we know that there's a particular chromosome, okay, they do have a particular gene therapy that they can use for these individuals. So they do have something called the anti-BCR-ABL therapy, okay. I would highlight this and say that this is another hallmark too, just like the chromosome, the reflective chromosome. And so that can also help with those individuals. They can also have an allogenic bone marrow transplant, okay, as long as they have a suitable donor. The autologous one is not as effective, having their own blood cells reinfused. As I told you before, everyone's not that healthy enough to have that done. So they will most likely have the one with the donor. Okay. And they say the blast stage of CML is basically AML, okay, in very poor prognosis. So let me show you what that means. So, really quickly, remember how I said we have the whole maturation process and when it's mature, okay. So let's just say that this is the immature stage, and then this is the mature stage. Now, the immature stage, we already know that this is where we have our acute leukemia. Okay. Now, just to give you another term, because you'll see this in your book and probably other textbooks, they also call this the blast stage. So when you hear the term blast stage, that just means that is the leukemia that has attacked at the immature phase. Okay, so it's just saying another way of saying acute leukemia. And we know this is chronic. Now, just to give you a heads up, and this is why they're saying that it's a very poor prognosis, at any time you have an acute leukemia, it is a poor prognosis. It's more aggressive than chronic leukemias, okay, in general. And so they tend to progress very fast, okay, which ends with severe outcomes. Okay, so acute leukemias, and we'll go into that with more detail. Okay, so let's go now to AML. AML, 80% of cases are adults. The median age is 64. Let me tell you this now before I forget. Most, they say that for leukemias and lymphomas, that males tend to be more at risk than females. Okay, and that's across the board for any leukemia or lymphoma. I don't know why, I have to look that up, but they say males are more.
I had a question about CML.
Yes.
Is it terminal?
It depends on how aggressive it gets.
So there is a possible chance for people to go into remission with CML?
Yes, there is treatment for it. There is treatment for it for them to get into a long-term. Now, keep in mind, with any leukemia or any cancer for that matter, when I go over treatment, let me just say this. The treatment, it varies. It really varies as to how aggressive that cancer is. Cancer, keep in mind, we all know it behaves whatever way it wants to behave. So it depends on how aggressive that cancer is getting, or what stage they're at. So some things are more fatal than others. Like when we talk about acute leukemias, they tend to be more fatal, from my understanding, overall than chronic leukemias. However, can someone die from CML? I'm quite sure, yes. It's just a matter of how aggressive it's going to be, you know. But they do have a treatment. So I don't know the exact percentage of how many people are go into a remission with this. But they do have treatment, and yes, they can go into a remission with this particular one. Okay. Now, AML, yes. So median age is 64, as I told you before, and this is again across the board with any leukemia, lymphoma. They say men tend to be more at risk than females. This is a malignancy, yes, of a myeloid cells, and what they look for in a biopsy to diagnose, a definitive way of diagnosing this, is doing a bone marrow aspiration to where they look for these leukemic cells, and they have to find over 20% of immature blasts, meaning immature leukemic cells. So that's what they're looking for. Now, I'm going to omit something here. There are a number of different subtypes, and I'm not going to hold you responsible for that, okay, because you would hate me, but had you memorize all the subtypes. So, this is the issue. You see how the acute phase, or the immature phase, it has all the different levels. So, there's like more than this, way more than this. So, each different level has a different name, because they all have a different subtype. Why is this important? Because some types are more curable than others. Okay, and so that's why they have to name it. There's a whole nomenclature for it, and we're not going to get into all of that. I don't think it's necessary for you guys to know that for nursing. However, I'll show you when we get to that slide. Now, the most common type of AML, they say, is acute granulocytic leukemia. If you see the term, and just highlight this, if you see the term acute granulocytic leukemia, it is the same thing as saying AML. So just in case if you see it in another textbook, they use that name sort of interchangeably. And they describe these cells as having a very large segmented nucleus with fine chromatin. Chromatin is just large and just kind of hanging out. Well, I shouldn't say large and hanging out, but it's there, which means that we all know that chromatin has to condense to make the actual chromosome. So chromatin really shouldn't be just hanging out freely in the nucleus if we're talking about a mature cell. This describes the immaturity of that cell, okay, saying that we can see chromatin. So this is a picture of it. Now I know that looks all kind of strange. This is not a lymphocyte. Okay, I know it looks like a lymphocyte. Keep in mind that we're in myeloid tissue. This is myeloid lineage. So this is one of the myeloid cells. Believe it or not, this is a neutrophil. Okay. Now, a couple of things here. This is an immature neutrophil and it's a cancerous neutrophil. Okay, this is why it looks totally different. This neutrophil is immature in the area of the cytoplasm. So if you look at the cytoplasm, it has granulars. It looks like it's coming out, but not complete as of yet. Not like the other one we looked at. And so it's not completely formed, okay, the cytoplasm with the granules. When you look at the nucleus just looks like one big blob, okay, and it's taking up most of the cell, kind of like a lymphocyte, but it's not. That means that that nucleus really has not taken on its shape as of yet, okay. So the chromatin, keep in mind, has not condensed, okay, to form natural chromosomes, and so all that genetic material, and there's an alteration also that's occurring, which is why it behaves, it looks that way. So this nucleus looks that way because of the immaturity and the cancer. Now, another thing, you see how that's all clustered together, okay? That's also a sign of the cancer. Acute leukemias tend to have more of a clustering effect. And so if you see cells all on top of each other, okay, that's not a good sign, okay, because that's almost like, if you want to imagine, like it's forming a tumor or something, okay? So they're all packed in together. And then in the background there, obviously those red blood cells don't look that great. Okay, so this was the slide I was talking to you about the subtypes. So you see all that wording there and numbers, okay? Yes, I will save you from that. That's not necessary. However, they do have a particular nomenclature, okay, or I should say, system that they use to code each and every subtype level. Okay. We don't need to get into that. I think that's even probably more so too for genetics. So we can cross this out. Okay, so it is important to look at the morphology, which is what we're doing with these slides. Okay. Oh, I forgot to tell you. The pictures that we're going over is on your image sheet. Okay, so if you want to just follow along, all these pictures are in the paper that I gave you to hand out. So yes, looking at the morphology is very important so we can distinguish, okay, what this is. The presentation, they say, of AML is very similar to ALL. Okay, so when we talk about acute leukemias, leukemias kind of have all same signs and symptoms, but they say they have a hard time telling it apart just from signs and symptoms. So that's basically what they're saying. So obviously looking at the peripheral blood smear and things like that will help define it. Bone marrow anemia, thrombocytopenia, infection, you know that that's across the board with any cancer, okay, or leukemia. Common sites of infection. This is important to know. Again, this goes a little more into that management. Here we go talking about infections again. So, skin. GI stands for gastrointestinal. GU stands for genital urinary. And respiratory tracts. Okay, so make sure you know those 4 sites. Those are the 4 common sites of infection, which means that those are the areas that you will be looking for in your patients for infections, because they're definitely going to happen there. Now, what does those 4 areas have in common? They all kind of have something in common that kind of makes sense for these patients getting infections. Well, it is tissue, yes, and mucous membrane, but it's tissue and mucous membrane where? Coverings to outside. Very good. They're all to the outside environment, and they're all openings, okay, in those areas. Which means, so say for example, they may have a skin lesion or infection, gastrointestinal, maybe they may get some sort of gastritis, genital urinary, they could have a UTI, okay. So those types of infections are going to be more prominent in those areas. Symptoms are abrupt, which I already told you, they're very fast, okay, so they'll know. The prognosis, they say, is worse for AML than ALL. I'll give you percentages there. I do want you to highlight this last bullet point. So even though I told you not to memorize all the different subtypes, I do want you to know that the acute promyelocytic leukemia is the most curable of the subtypes. That one is the most curable of all the subtypes. Okay, so this slide gives you a nice little diagram or box of going over the characteristics of acute and chronic leukemias. This, I think, will be a good thing to include in your study guides when you're going to prepare for next week's test, just to add in the characteristics. Okay, so they're there for you. Okay, so the prognosis and treatment, I'm just going to try to sum this up. The prognosis, well, I should say not the prognosis, but the treatment here is, as they say, individualized therapy. Again, it's hard to say what's what, okay, because it depends on how aggressive it is. But the goal, we know, is to get this patient into a complete remission as quickly as possible and hopefully keep them there as long as possible. And even when complete remission is achieved, they will definitely continue chemotherapy, okay, even after. And this is a protocol. You don't need to know this. I don't know if you guys have over to nursing, but this is just a chemotherapy protocol. So chemotherapy is the treatment of choice for this type because, again, they want to get as aggressive, okay, as possible and quickly. And yes, that's it. Okay, so lymphoid neoplasias. We already talked about what cells fall under the lymphoid lineage, so we know that already. We already discussed what's considered a leukemia and a lymphoma, so we know that. So let's just get right into it. Let me see this. There are subcategories of B cells and T cells. Okay, and so when we talk about lymphoid neoplasia, sometimes they attack a B cell, sometimes they attack a T cell. Honestly, I haven't really heard much of an attack on a natural killer, even though they have it listed there, but I just learned about that from my studies. I haven't heard much of a leukemic natural killer cell. But anyway, it could happen. So it's mainly B cells that are attacked, and then some T cells. That's kind of how it goes. Now, if at any point a person has a leukemia in a T cell, I do want you to know that that's a very poor prognosis. That for sure is almost fatal, and I'll tell you why. T cells, as I told you earlier, help attack cancer-infected cells, which means if you have a cancer now in a T cell, that's not good because that can't help fight. Just like the same premise of patients that have HIV. The virus attacks the T cell where the T cells will attack the virus, okay? And so that's a problem. So when patients do have a leukemia in a T cell, not a good thing, not a good thing. Okay, so we can cross this out. Those of you who are taking, you guys, what's the course that they have? Capstone? Okay. Those of you who are taking capstone, if you do cancer, you guys will probably get more into all that genetic research. Genetics, that's a whole nother course. Okay, so CLL, chronic lymphoid leukemia. So we know what this is, it's mature, it's chronic. Lymphoid, we know what cells it could possibly be attacking. And this accounts, they say, for 30% of leukemia cases in the US. I will tell you this right now, if you want to jot it down, that CLL is the most common adult leukemia. CLL is the most common adult leukemia. So 95% of it will attack a malignant B cell. 5% can attack the T cells, and again, this is very aggressive if it ever attacks a T cell. This is the one that I was saying to you that is usually found on accident by routine blood work. So I guess you can say that's kind of a hallmark for this one. So routine blood work, patient goes in, they have no idea. And the reason why is this, because the signs and symptoms slowly develop, and in the beginning it's more like maybe a fatigue, bone pain, things like that. And this pretty much attacks like after 50, like 60. So, you know, what's the chances of a person 60 having bone pain? Okay, that's common. So, you know, unfortunately it goes, I don't want to say misdiagnosed, but it might go underdiagnosed in the beginning. So when they are symptomatic, they will have, yes, the fatigue, weight loss, okay, anorexia, okay, infections. When it attacks the lymphatic tissue, they'll have different signs and symptoms, such as an enlarged lymph node. Okay, so let me go over that. And usually when I go over this, people go home and start feeling on themselves, making sure they don't have this. So when you have a lymph node that is large, okay, if it's painful, so say for example now everyone's kind of like going through a little head cold, okay. If you have a head cold and you have your cervical lymph nodes that are, you know, definitely elevated, and you touch it and it's tender, that's actually a very good sign, okay. That means that there's inflammation there, that means that the body is doing what it's supposed to do to attack whatever is going on. However, if you have a lymph node that's large, you touch it, it's not mobile at all, and you don't feel it, like it's not painful, it's painless. That's not a good sign. That means most likely that's some sort of tumor or mass, okay, or cyst type formation. So that's the difference. So when these individuals have this now infecting the lymphatic system, they don't have any pain with it, okay. Pain is a good thing because that's telling us it's going the inflammatory route. If it's not painful, then that means it's more along the cancerous route. So, enlarged spleen can also develop. Bone marrow, we know, is all going to be suppressed. Okay, so we know that. CLL, these cells will also have defective apoptosis, so they will also have that decline in apoptosis, which makes the lifespan of this cancer longer. And again, it's from B cells. So, this one looks a little different, and so let me just go over some things. So number one, here, here, and here. Those cells are on their way out. The rest of these dark cells are lymphocytes. Okay. Now, number one, going back to anatomy. Do you remember scanning the slide and finding a lymphocyte? How long did it take you to find it? A long time. Okay. Here we have like 7 lymphocytes in one field of view. Okay, so even though they're not all clustered together, to have that many lymphocytes all together is not a good sign, and especially the way they look. Now, these lymphocytes, as you can see, they have some cytoplasm around it, so it is supposed to be the mature phase, but they really don't have a lot of cytoplasm. However, the nucleus is taking up most of the cell like a normal, mature lymphocyte. But the nucleus looks different. It almost looks granulated. And the reason why it looks totally different, again, is that speaks to the malignancy. So that tells us that it's cancerous, and most likely it's probably chromatin just hanging around and not condensed as of yet. But that's that. Now, treatment. They didn't list the treatment here, but I'll give it to you. So, yes, as we know, some can be worse than others, and again, it all depends on what's happening, okay, with the cancer. They don't have the treatment in your slide, so if you want to jot down, the treatment they use for CLL is chemotherapy. And if chemotherapy alone does not work, they could also include stem cell transplant. So chemotherapy and stem cell transplant. Okay, so ALL. Now this one is sad. All sad. But this one attacks children. So ALL, this is malignancy of lymphocytes. Okay. Again, 80% of it attacks B cells. There are some 20% that attack T cells, and we already know what happens with that. They are looking for lymphoblasts, meaning the immature leukemic lymphocytes. Okay, so they're looking for immature lymphocytes that are leukemic. So, here we go. Now that doesn't look good. And so what's happening here, number one, this is immature. What's immature is this. You see here just like a tiny bit of cytoplasm here and there, okay, which means that the cytoplasm hasn't completely formed. Okay, so that makes it immature. The other thing that makes this cell immature is this cell is very large, as you can see. It's real big. It hasn't really condensed and taken on the shape as of yet. And a lot of that too, probably sitting like that, has to do with the cancer. Also, the other thing that makes this cancerous is that extreme clustering effect, as you can see. Okay, and that's pretty extreme. And then look at the background with those red blood cells. Okay. So this is ALL.